So my name is Riccardo Cappato. I'm head of the Electrophysiology and Clinical Arrhythmia Department at Multimedica Hospital in Milan, Italy.
My name is Rui Providência. I'm a professor of cardiovascular epidemiology and evidence synthesis at University College London, and also a cardiology and EP consultant at St. Bartholomew's Hospital.
Catheter ablation has gained extreme popularity because it's the only strategy enabling curative treatment of atrial fibrillation. In spite of its promises, after more than 25 years of activity, the efficacy outcomes have not entirely met the expectations, such that the currently expected success rates differ from center to center and tend to be in the range between 55 and 75%, depending on the type of atrial fibrillation which is subjected to catheter ablation, the experience of the centers and the strategy used. So there is still a significant number of patients who are not successfully treated with this strategy. And in addition, eligible patients at present do not represent the majority of patients with atrial fibrillation in the real world. Now, why a new guideline document on catheter ablation? Given the premises, we also know that since their introduction, guidelines have been a very valuable tool for a large population of stakeholders. While they are meant to help professionals in taking routine clinical decisions, we have to recognize that there are very few studies that possess the quality required to gain the level of guideline recommendation. In spite of that, very high volume redundant documents are being produced, typically reporting tables with extensive list of recommendation. And to compensate for the lack of evidence-based documentation, studies of incomplete quality are usually adopted by the committees of the various guidelines, enriched by subcategorization based on multiple and arbitrarily generated levels of evidence. At the end of the day, this is generating difficulty by the interested body to receive and adopt the guideline documents. ECAS thought that a way to compensate for these limitations would be to provide a concise document, easy to read, and which might become more user-friendly and more easy to be interpreted based on the rigorous premises that the document was introducing, to which I will allude in the remaining part of the conversation.
So adding to this point, I believe that the utilization of catheter ablation for patients with AF has increased clearly over the past few decades, but we still observe that patients referred and receiving this procedure, they are being treated mainly for to preventing atrial fibrillation relapses. So we are having patients that get treated mainly to improve symptoms or to reduce symptoms. And over the past 25 years, there has been slowly a growing body of evidence showing that the benefits of this intervention goes well beyond symptoms. And we felt that there was some discrepancy in what the recommendations say, what the currently available recommendations say on who should be getting an AF ablation and for what reason people should be getting an AF ablation, and the available evidence. So for that reason, we thought that was an area that needed to be addressed. And also in my previous experience and involvement in other guidelines, I started realizing that probably the standards of guidelines that we use would need to be improved. So I grew up in a time where, since the start of my training, I was reading ESC guidelines, and I accepted that as the highest standard. But then recently, looking at other guidelines done by organizations as the WHO, I understood that, well, methods and quality need to go well beyond. And I think that's a little bit what we try to bring into these guidelines. We wanted to do guidelines that are really guidelines, not slightly modified versions of consensus documents, because ESC guidelines, they have in some cases something like 40 to 50% of recommendations that are not based on any evidence. They're just consensus recommendations. And I think that was also what we tried to address with these new guidelines developed by the ECAS.
In order to familiarize readers with the straightforward comprehension of the guidelines, we created prerequisites for qualification relative to each of the three classes of recommendations that were introduced in the guideline documents. So class 1, class 2, and class 3 remains as in every other guidelines. The way we made them concise and more rigorous was by removing subclassification of A and B and subclassification into levels of evidence A, B, and C within each recommendation classes. You know, subclassification and levels of evidence are the best representation of the arbitration introduced by the body of authors within each recommendation, within each guideline document, to compensate for the lack of high quality production articles. Now, the main elements that we introduced were for class 1, we subcategorized them into evidence for superiority of catheter ablation versus controlled therapy on the one side, and evidence for similarity of efficacy and safety profiles between comparative technologies or techniques. These two subcategorizations apply to both recommendation class 1 and 2, because in class 1 and 2, you have evidence for benefit from catheter ablation. For class 3, we subcategorize into evidence for harm and evidence for non-benefit by comparative technology and techniques in catheter ablation. Now, the reason why we thought class 1 should be represented in our recommendation scheme is essentially based on presence of low risk of bias for all crucial domains, high precision of effect represented by narrow 95% confidence interval, absence of other contradicting similar high quality evidence, and compliance with the principles of directness, comparability in the reference trial. And all this data should come out from randomized clinical trials with a well predetermined working hypothesis and a volume of patients enabling acquisition of the working hypothesis. Now, for class 2, remember, we still have evidence for superiority of catheter ablation on the one side and evidence for similarity of efficacy and safety between different catheter technique or technologies. But the quality of the information where these data are collected from is of lower level, and namely is expressed by randomized clinical trials as secondary working hypothesis, insufficient sample size, premature termination. So good hypothesis which for whatever reason could not be brought to an end, but yet generated a level of evidence which was inferior to the class 1, but still sufficient to be considered by the readers as something worth to be applicable to daily clinical practice. And then finally, a real novelty of our guidelines, targeted meta-analysis on qualifying endpoints from these randomized trials for which the information was still not available for the reasons mentioned above. It is important to note that the targeted meta-analysis were performed by members of the author's team with the specific purpose of producing novel information that might qualify it as class 2, might generate new information, might provide more solid evidence on previous information on which consensus was generated in the absence of data, and might be available for independent research sources, hypothesis generating from the one side, and production of documents that were published or are to be published in conjunction with our effort. So the great novelty here was that the work generated in order to improve the quality of the information reported in the guidelines became an original document to be published as an independent research by the team of authors. Now, with reference to class 3, only high quality randomized trials as in class 1 were the source of evidence, but the outcome was, please don't use catheter ablation in this case, because either it harms the patients, higher death rates, higher complication rates, or because there is no evidence of benefit, and adding technology or techniques on top of the paradigm of catheter ablation in these days, which is PV isolation in the usual case, might bring to more harm simply because adding lesions without any benefit should be avoided in the daily practice. Now, an important issue in this regards is that we are open to new information in the next future that might remodulate the current recommendations, both with respect to class 1, 2, and 3. And we have programmed the next production of the guidelines in 5 years from now, except for those very unique conditions that might be generated by novel literature that are worth publication of data.
I fully agree with what Professor Cappato has said, and I would really like to emphasize that we decided that we could only recommend what we know and what we trust, meaning that we decided that all the recommendations would have to be supported either by RCTs or by systematic reviews of RCTs. We thought it would not be acceptable to do any recommendations, to make any recommendations based on observational studies or studies of low quality, or to have any recommendations based on our opinion, because otherwise, if we were to do that, it would no longer be a guideline. Then the second important and revolutionary thing in these guidelines was that not only we decided to provide solid, well-designed evidence and high-quality evidence, but we also decided to assess and appraise the evidence. What are the strong points? What are the vulnerabilities of the evidence that we present that underlies and supports the different recommendations? And then finally, the other thing I'd like to highlight is some very nice schemes and flow charts that summarize the evidence, the recommendations quite succinctly, and present the number of trials that support the recommendation, the number of patients included in such trials. And I think it's important for the reader to understand, I'm doing this based on a trial or based on 5 trials, including 5,000 patients, which is different from doing something based on a trial with only 1 trial with 100 patients. So I think these are important contributors of this recommendation, which sets the scene for a change.
Well, the biggest challenge is to compromise between the persuasive obligation that I was referring to before and their natural decision based on personal knowledge and the applicability in the individual patient. Even a very well designed, very well conducted, large randomized clinical trials only answer a single question, whereas the variability of the clinical picture faced by clinicians in daily practice it is very large. And it's hard to find patients who perfectly meet the entry criteria of those trials, enabling us to take a precise answer in response to a precise question. So the adaptability in the individual patients is mainly left to the art of medicine, as in the past. Whereas current guidelines try to give answers to each question, to each possible clinical questions. Now, based on the considerations made above, most of the questions raised in clinical practice are not answered by clinical trials. We therefore advocate for applicability of recommendations as useful tools to guide in the selection process, rather than persuasive obligation to read the recommendations from guideline documents and take their decision based on the recommendations reported in those documents. I would say this is the main message that we would like to deliver.
The other thing that we also want to emphasize is that, as Professor Cappato said, of course, patients in real world, patients in clinical practice, they're not perfect. They're not selected patients for trials. They don't fit within pattern or trials A, B, and C inclusion criteria. They're sometimes patients with quite nuanced and mixed conditions. So I think this guidelines gives a little bit more of flexibility. Then the other thing that we also tend to find quite often is that we're looking at the guideline and we're looking at recommendations, and then frequently we would notice that for a specific condition or a certain condition or an indication, we would not find trials that we know and that should have been included there. So what we've done here is for every indication or for every group of indications, we've done a systematic search and review to make sure that all the trials informing that type of decision and recommendation were represented in this guideline. And if some of the evidence was not included, at least there was some justification to support it. So I think this type of this attempts to address that gap probably will facilitate, will help physicians adapt and incorporate these guidelines in their practice, because all the evidence will be there. Of course, in 5 years' time or in 2-3 years' time, probably there'll be trials that we didn't include because the guideline always needs to be updated. But at least this principle and trying to have everything as much as possible up to date, I think that's an important step that should be facilitating the introduction and applying this into real world.
Finally, the document is only 25 pages long, including 4 pages with references, is easy to read. We hope easy to memorize according to the method that we were reporting. Most of the relevant information that can be used as a consultation model to readers is available in the supplementary material. The supplementary material contains not only the justifications for why did we make some decisions rather than others to improve the transparency required also by regulatory authorities, some models used to produce guidelines, but also provides tables where ongoing clinical trials listed in the website clinicaltrials.gov are available. We have there a list of 243 ongoing trials, which will serve the readers to consult on which questions are currently being answered by ongoing trials and which questions will likely be addressed in the next document of the guidelines to be produced in 5 years from now. We think this is an important tool for readers to know, okay, if we don't know what to do in this specific condition and we have to rely on the old art of medicine to take our decision, we know that some of the topics related to the specific issues are going to be addressed in the next future, and we will probably have a more solid answer to our currently unmet questions in the specific case. So to summarize, very rigorous criteria according to which we may now elect our patient to a class 1 or 2 recommendation indication, or we may exclude the indication according to a class 3 solid recommendation level. A lot of uncertain conditions in which we don't know how to proceed, and we may take class 2, 1, 2, or 3 as reference now and use the art of medicine to take the decision on an individual level, and a lot of ongoing studies that may help us in the next future to enrich the rigorosity required to take decisions in currently unmet situations. This question goes beyond the scope of the guidelines and has a lot to do with the way each of us looks at the current knowledge, and now should this be applied in order to accomplish better results in the future. Now, catheter ablation has essentially relied on 2 major schemes so far. The first scheme is to identify the source of AF in the individual patient and ablate the source, with the hope that by ablating the source, you will eliminate atrial fibrillation. The second is reference to the old data coming from surgical atrial compartmentalization, which is a cut and sew strategy, ultimately subdividing the atria into smaller chambers in which the electrical activity cannot be as chaotic as in the normal atria. And chaos is the essential dominating force enabling perpetuation of clinical episodes. So if I can compartmentalize the atrium, I don't care where the atrial fibrillation originates from, but I essentially mitigate the ability of single atrial episodes, atrial fibrillation episodes to perpetuate. So as you can imagine, these 2 conditions are complementary to each other and goes into mutually supportive mechanisms of clinical episodes of atrial fibrillation. Targeting the source of atrial fibrillation has shown an effective way to use catheter ablation in clinical practice, because if we can isolate pulmonary veins, we may isolate a significant proportion of potential foci precipitating atrial fibrillation, and by doing so, we are in a good position to eliminate a substantial proportion of AF episodes. And this has proven effective in a significant proportion of patients with paroxysmal atrial fibrillation, in a lesser proportion of patients with persistent, and an even lesser in patients with permanent atrial fibrillation. The intent of producing atrial compartmentalization by catheter ablation has proven ineffective for a number of reasons that are beyond the time available for this discussion. But the use of new techniques and technologies tends to bring the medical community believe that we might be in a better position in the next future to reproduce the surgical cut and sew strategy using catheter ablation procedures. One way for me to possibly increase the variety of options that I've tried to summarize in my discussion includes the ability to recognize atrial foci precipitating atrial fibrillation outside of the pulmonary veins. I think this is the next frontier for research in this field. Should we be in the position to recognize the sources of clinical atrial fibrillation precipitating single episodes in the individual patients prior to ablation, we might then be in the best position to test the concept that ablating those sources in the individual patients might indeed result in better outcome. It all needs to be proven, and clearly the technology enabling recognition of these foci during clinical episodes is far from being accomplished. But I think this could be a very helpful way for the medical community to hope for better outcome in every single category of atrial fibrillation.
I think those two aspects are key. We need more powerful forms of energy that will produce more durable and long-lasting lesions. We also need it not only to be more powerful, we also need it to be safer, which is a difficult compromise. You want to be more powerful, more efficacious, but also simultaneously, you will also want to be safe. Then the other important aspect that was raised by Professor Cappato is being able to detect extra PV triggers in an accurate and let's say a replicable way that can be done by everyone, not only by a few expert centers, because AF is a global epidemic. We need to understand what is the ideal set of lesions. If in fact, if it goes beyond the extra PV triggers and we need to do lines, we need to understand if we need to do lines, which are the lines that need to be done. But I think we cannot disregard the complexity of AF. And AF is a condition where patients have multiple comorbidities. And more we know that there is an important role for the management of the different comorbidities and risk factors. And that will also help us clearly to achieve better outcomes. And then finally, I think we also have to keep our minds open and understand that all this might be slowing down the disease process, but we need also, and we need to develop, we need to keep our eyes open for new drugs in the future that can just block and prevent and delay the disease process. And we can be doing lesions with catheter ablation, with catheters. We can be controlling risk factors. But if you have a sick atrium because there is different biological processes that are not happening the way they should be, we should start more and more to think and obtain different drug options to help us on a molecular level, because otherwise we have, I don't know, we have 80%, 85%, 90% of freedom from arrhythmia relapse for paroxysmal AF at 12 months. But we know that's not 100%. We have even less for persistent AF. And then we know that we have patients that are cured for 1, 2 years, 3 years, but then they start to have late relapses. So it means that ablation is a big, big part of the solution, but even if we get more efficacious and safer energy sources, and if you really need to know what to do for each patient, I don't know if that will allow us to achieve a permanent cure. And I think that's the important aspect why we need to continue on looking at these patients and addressing all the other risk factors and possibly getting a drug or drugs, different drugs that will prevent the progression of the disease. We know that AF ablation can prevent progression of disease. That's been nicely shown by trials. But if we want to go far beyond, if we want to go beyond, we need more options. We need probably more things added to the equation.